Uh, Morning, sir. Should I start, sir?
Praveen, please start.
Yes. So, morning, everyone. Today I'll be ta- talking about graph preparation. So, as you know, with each case, and with each certain graph option is pretty variable. The main determinant factors of the graph are primarily the demands of the patient, and also secondly the experience and the expertise of the surgeon in harvesting and preparing the graph. And there are also few authors who seem to prefer allograft as good as autograft. But so many studies have shown that autograft is definitely unequivocally better than an allograft. So by example, this study by Engelmann et al. In 2014, they compared allograft as autograft for ACLs, and they have proven that autograft works way better as compared to allograft with regards to patient-related outcomes, lesser failure rates, and also higher rates of return to sports. So autograft is the option to be preferred. And with regards to hamstrings BTB, though there is no long-term superior, seems to be better stability with BTB at the initial phase. Long-term results with respect to post-op complications and post-op scorings have found that hamstrings work as good as BTB. Hence, there is no superiority of one graft over the other. Okay. The next most important determinant factor to be considered in a graft is the graft size. This is the most important variable since it directly implicates on the strength of the graft as well as thereby the longevity of the graft. So the ideal graft length is should be more than 8 mm, as put forward by this paper by Conte et al. In 2014, where they showed that it's a systemic analysis of four articles, where they found that grafts with a diameter of less than 8 mm has significantly high failure rate of as high as 6.8 times compared to other grafts. And this is particularly important problem in patients less than 20 years of age, which is considered to be a high risk for failure. So this sizing becomes very critical. Sizing becomes problematic, particularly in females, both in very young as well as elderly females, since the hamstring grafts is taken as an option, may not
Praveen,
have.
1 minute, Praveen.
Yes,
Dr. Hakam, can you mute your mic, please? Thank you.
Okay, sir.
So this can become problematic in females because of the small hamstring size. So graft preparation techniques have been aimed to improve so that get an adequately sized graft of at least 8 mm. So can we know the graft size preoperatively? Again, the same paper by Conte et al. 2014. They also investigated other predictive factors which can reliably measure the graft like preoperatively. So of the various factor studies, the most important, most reliable factors they could come up with is only the height of the patient and the MR cross-sectional area. So this is the final conclusion of their study. So as you can see, the MR cross-sectional area is a very good and reliable measurement of the final graft diameter measure we get in drop, and also the height of the patient. So as you can see here, to get a graft of 8 mm, the average height of the patient should be 185 centimeter. So just quickly regarding hamstring harvest technique. So This is the paper by Olivos Meza et al. And published in 2020 regarding hamstring graft harvest. So the most important anatomical landmarks, apart from the landmarks for scopic portals with regards to graft harvest, is the tibial tuberosity and the posteromedial border of the tibia. So as you can see, the tibial tuberosity and the posteromedial border tibia mark. While going through the graft harvest procedure, it's imperative that the knee is kept in 90 degrees flexion, and if possible, slight hip external rotation are advised to reduce the tension on the saphenous nerve, hence probably reducing the risk of injury during incision. So once the markings are made, a horizontal line is made along from the tip of the tibial tuberosity to the posteromedial border of the tibia, and it's divided into thirds. The hamstring tendons are usually palpable on the middle third of this line. So skin incision is done with care should be taken that sharp dissection is done only to the skin and the immediate underlying subcutaneous layer. The deeper dissection should be carried out bluntly. This blunt dissection can be used with just blunt forceps or with finger with the wet gauze to move away all the surrounding soft tissue. This helps primarily to prevent inadvertent injury to the MCL, and also is supposed to protect the branches of the saphenous nerve, branches of saphenous nerve just going underneath. So once the blunt dissection is adequately done, we should be visualizing the sartorial fascia. The sartorial fascia appears as a pearly white layer just on the medial aspect of the tibia. Again, during this step also, it is imperative that we maintain the knee at 90 degrees of flexion because this gives just the adequate amount of tension for the graft, tension of the hamstrings, so that the hamstrings can be easily, if very prominent, can be seen or at least palpable as a small over elevation or a step along the medial aspect of the tibia. So as you can see here, once the deep dissection is done, the hamstrings can be felt for a small step between the fascia and the hamstring, which corresponds to the superior aspect of the gracilis tendon. So blunt dissection is carried out at the superior aspect of gracilis, directed inferiorly. So basically creating a plane between sartorial fascia and the MCL. Again, this measure is this sort of dissection advised to prevent injury to the MCL. This once the dissection is carried out towards the laterally towards the tibial tuberosity, vertical incision is done close to the of the sartorial fascia is done close to the tibial tuberosity. So the blunt dissection is carried out from the incision site towards the tibial tuberosity, and then vertical incision is done at the tuberosity site. So ultimately, this results in an inverted L-shaped incision of the sartorial fascia. Once that incision is completed, the dissection medially is extended along the course of the superior aspect of gracilis. So ultimately, this is the final incision of the sartorial fascia, which from where the tip of the superolateral vertex is held, and the sartorial fascia can be reflected out outward in open fashion. So when the substance of sartorial fascia, you can see the hamstring tendons lying. So as we know, the gracilis is the superior tendon, and the semitendinous lies lower below. So with the tendons visualized, the semitendon ST should be released from the sartorial fascia, again with blunt dissection, and should be pulled in towards a vertical cut and released at the insertion site at the tibial tuberosity. It is also important to take a small flap of periosteum from the insertion site, since it helps in better healing of the graft. Once the ST is removed from its attachment, it is held at its 5 mm from its tip, and either using cinch knots or can be held with artery forceps, and should be looked for adhesions. The semity usually has prominent 3 to 4 adhesions usually, and should be looked for and cut precisely. Usually, as adhesions go into the gracilis and the semimembranosus. Primarily, finger dissection can be done to identify the vinicula, and then a thick band should be identified, hooked with the artery forceps, and then cut. Once the adhesions are removed, the tendon is held with a non-dominant hand, and the tendon stripper is placed in the dominant hand. The tendon stripper is passed through, and the dissection is stripping of the tendon is done along the direction of the fibers. Another tip intraoperatively to identify the muscle tendons is that gracilis usually has a more circular, uniform muscle belly, in very similar to the orientation of the tendon, whereas the semity usually has a more bulkier muscle belly as we go progressively. This can also be used to identify when in doubt. So as you can see here, the tendon is pulled, held in tension, and the tendon stripper is advanced. And if any resistance is present, it should be withdrawn and advanced appropriately. So just a few key points to be kept in mind. The gracilis can deceptively appear thicker at the insertion site compared to the semity. Hence, it shouldn't be confused, and semity should be identified based on its location. As in, the gracilis superior and semity always lies inferior. And the periosteum should always be included in the graft, since it is found to have humoral factors which can help to promote better healing of the graft, and hence should be included in the graft whenever possible. If muscle relaxation is inadequate, and if the tendon is not held in position with cinch knots, it can retract back. Usually can be identified with the arthrosis. If not necessary, the scope can be introduced to locate the tendon. The true diameter of the semitendon tendinosus is usually after 5 to 8 centimeters of length, because since it has a more horizontal orientation along the at its insertion site. If vinicula is missed and the stripper is advanced very aggressively, it can deviate and along the course of the vinicula, and hence can snare the tendon and we can lose the diameter. Hence, if at any point, if there is high resistance encountered while harvesting the tendon, it should be withdrawn and advance in the direction of tendon with a gentle twisting motion. So another technique is described in Strobel is when we're just planning to harvest only semity. Very similar, only difference being the incision in the sartorial fascia is placed at the ridge between the gracilis and the semitendinosus. So the fascia is lifted up and a horizontal nick is made and the blunt dissection is done. And the semity is again harvested from the sartorial fascia through blunt dissection. You can say the orientation of fibers of the MCL can be seen here. So semity is held and dissection from the attachment site is done. If needed, the periosteum or the attachment site can also be cut, so it is peeled off along with the tendon, and the vinicula looked for and removed. And finally, once the tendon is harvested, the sartorial fascia, it is advisable to close the sartorial fascia. The primary advantage of this technique is that since only a single tendon is being harvested, it saves time, and the rest of the anatomy is preserved. The gracilis as well as the proximal half of the sartorial attachments are preserved. One disadvantage is that requires more precise identification with the fascia in place of the semity and gracilis, which might be challenging at the beginning. So how do you decide whether you need a gracilis tendon, additional gracilis graft or not? So as we discussed before, the minimum ideal diameter of a graft is at least 8 mm. Similarly, the amount of graft in each tunnel is about 15 mm of graft in each tunnel. So this is an algorithm put forward by Fritsch et al. Published in 2017. So basically, once the semity is harvested, depending on the length, we convert to 4-strand tendon or 3-strand graft. So if it is less than 23 centimeters, then a three-strand preparation of the graft is done. And if the graft is still less than 7 mm, then an additional gracilis is needed, which should be 3-stranded if it is less than 7 mm. If the diameter is between 7 to 8.5 mm, just a 2-stranded gracilis tendon should be adequate. So that making a 5-strand graft. And if more than 8.5 mm, it can be used by itself. Similarly, if it is more than 23 centimeter, quadrupling of the graft is done, making a 4-strand semity. If less than 7 mm, again a 4-strand gracilis is added. If 7 to 8.5 mm, 2-strand gracilis is added. If more than 8.5, ST can be used alone. So moving on to graft preparation. So as you know, once the tendon is harvested, is placed on the graft preparation board, all the adherent fat and the muscle fibers should be adequately removed. And once it is removed, the length of the tendon should be measured. Point to be noted is that this proximal part of the tendon, up 2 to 4 centimeters, might be frayed and may not be usable. Hence, the tendon up to adequate length should be measured. The tendon, as discussed, should be at least ideally 24 centimeters long. So once the graft is prepared, the diameter of the graft is checked by snaring the loops on a thread and passing through the suture sizing device as we see. So when passing through the sizing device, slight resistance is the appropriate size. It shouldn't pass freely. This will imply a uniform snug fit within the tunnel once it is passed. Another point to be noted is that an untensioned graft is usually 1 mm larger. So the sizing of the graft at this stage might be 1 mm larger. Hence, the femoral tunnel should be usually it's recommended to be under drilled by 1 mm, and the final sizing of the graft should be done, and the femoral canal can be re-drilled if necessary. So then the tendon is mounted here. They convert single tendon to double stranded tendon, divide into halves, and they're preparing tendon. So tendon is mounted on the tendon board and is kept under tension. It's fixed with all soft tissues are removed and fixed with non-absorbed sutures at the ends of the tendon. The proximal broader part of the tendon, which should be converted to more uniform with coordinating sutures. This is the orientation of sutures to be placed at the ends of the tendon. This gives adequate tensioning of the tendon when pulled. And if the periosteal flap is present, it should be included in the femoral end of the graft. Once the tendon is stitched and prepared, the graft the graft should again be resized and the final size is determined. And the pre-tensioning of the graft is also mandatory. Both manually as well as using the board should be done. This allows for better alignment and better tensioning of the sutures. So just moving about preparation technique of with the different types. Starting with two-strand techniques is the simplest of all. When the tendon is looped on, bent on itself and just tied into double strand, it can be done with submiti or gracilis. So as you can see, a suspensory device is fixed at the middle, and the ends of the tendon are sutured together, and the mark for slipping is made at the middle of the tendon. So non-absorbable stitches should be placed at the end of the tendon. Three-strand preparation, as discussed, is usually indicated for less than 24 centimeter grafts and is slightly more complicated. So here, as you can see, the tendon is folded into S shape, and the two ends of the free ends of the tendon are so tendon is divided into equal halves, three equal halves, and markings are made for the suspensory device is connected one of the loop ends, and non-absorbed stitches are made at the ends of tendon. Then the single strand only on the femoral side is sutured onto the rest of the loop. So you know, this is the final orientation of tripled graft. So marking stitches made at the necessary point for flipping. So primary advantage is since there's only three strand, it gives for better graft length, and thus there's minimum suture material seen present within the tunnel site, and there is better tensioning of each strand as compared to quadruple graft. The disadvantage is that since it's a smaller graft, it might be weaker graft, and this is slightly more complicated preparation. So next technique is the quadrupled ST, which is done when particularly only when all inside fixation is being done. So the graft length with all inside with only a graft length of 240 mm. So a quadruple graft will only be up to 60 to 70 mm in length. So as you can see here, the double graft is passed through the tibial fixation device and the free end suture, and then rest of the and the free end is again sutured onto the tibia other end of the graft, and this is passed with other suspensory device on the other femoral side. At this point, if the graft is too small, an additional gracilis can be done, making it a 6-strand graft. This is also looped around and sutured onto the rest of the tendon. So 4-strand technique is the most commonly used technique where both semity and gracilis are harvested and used together. Point to be noted is that the grafts are usually inverted and stitched such that the proximal ends of the gracilis coincides with the distal end of the semity. This is more suited for hybrid fixation since so two grafts and just double, it allows for longer grafts and is more suited for hybrid fixation and also has good strength. Disadvantage is morbidity. Gracilis harvest morbidity. and longer preparation time. So 5-strand technique, as we discussed before, is in case of in a small diameter 4-strand graft. So a triple graft with the overlaying gracilis graft. So main advantage is it maintains the length and increase diameter, and the increased length allows for hybrid screw fixation. So each end of each tendon should be stitched in separately, and the femoral portion should be sutured together. So this is a technique in this folded tube technique where the broader distal part of the tendon is wrapped around the tibial, and broader proximal part is wrapped around the tibial part of the tendon, which is more cylindrical. So this is folded and sutured in this fashion. This allows for a inner tube-like strand. Main advantage is the less suture material in the bone and more homogeneous graft. It requires more meticulous preparation, and full tensioning of the graft can be done only after fixation of the graft. So this is a quick video on describing the. So this is a double strand and a 4-strand tendon is prepared. As you can see, uh, so similarly, 5-strand and 6-strand grafts are prepared with additional grafts onto the prepared grafts. So just a quick note on button flipping when you're using a suspensory fixation. So first 4 images describe the normal technique to be followed for using a suspense fixation and flipping the graft. So there should be a leading loop and a flipping loop. So the graft should be pulled just from the tunnel, just proximal to the tunnel, and then should be flipped, and then the graft should be pulled down so that it's seated in place. This is what happens if the graft is, if flipping is attempted when the graft is still in the tunnel, it can get hitched onto within the edges of the tunnel. And also, this can happen if the graft is pulled very proximally and excessively pulled with the pulling loop, the over flipping of the graft can also happen, where the entire flipping vortex is twisted by 180 degrees and still the graft wouldn't be engaged. So in such cases, if pull down the tunnel, the button wouldn't be engaged onto the cortex. So it should be re-maneuvered and pulled appropriately so that there is held in tension at the end of the cortex. Just quickly about BTB graft technique of harvest. This is the paper by Frank et al. In 2017 describes in technique. So just as with the STG, the most important landmarks, the tibial tuberosity, and of course the patellar borders. So a vertical incision is placed in the inferior pole of patella along, which advised to be placed more medially along the patellar tendon to allow for room for the tibial tunnel to be placed. So sharp dissection is done, and dissection is done for the paratendon and retracted. So once that is the paratendon is removed, the length width of tendon is visualized, in which up to middle third is measured and marked either with a osteotome or with a pen. At least 10 mm of tendon should be left medially intact. So the tendon is marked and incised longitudinally from proximal distance, starting either on the medial side or the lateral side. Care should be taken not to make the incision narrowing or widen from the other side. Should be kept as parallel as possible. As we come down, the tibial plug is harvested first. The ideal tibial plug should be 10 by 25 mm. With the cortex is cored with the saw or with the osteotome and then traced with the saw. Again, care should be taken not to go deeper than 8 to 10 mm, which should be guided by the marking the saw. The graft should be directed towards the center of the graft. So, as is harvesting accurate triangle shaped graft on the tibial tuberosity. Distal cut is also advisable to be directed 45 degrees to longitudinal cuts so as to avoid a stressor at the harvest site. And the graft should be removed. It should be either cut or osteotomized to remove. It shouldn't be pulled out. Do not levering out can cause increased risk of fracture of the graft or the surrounding tibia. Hence, recut with the saw if necessary. Do not lever out. So as you can see, the tibial tuberosity cut is being made. Then following that, for the patellar grafts, as we move proximally, similarly, the ideal patellar plug we aim for is a 10 by 20 to 25 mm patellar plug. Again, scored with the osteotome saw and then sawed. Others will go only 6 to 7 mm deep so that to not avoid the articular cartilage. It is directed about 30 degrees towards the center and to harvest the trapezoidal graft. Again, proximal graft should be at 45 degrees to avoid stress tracer. Advisable not to mallet, just remove the scissors or if necessary, make recuts. As you can see, the patella is once the cuts are made, it is being delivered using an osteotome. So this is a paper by Santosh and Davis I came across, published in Asian Journal of Arthroscopy in 2020, where instead of a vertical incision, document the use of an oblique incision for reducing the incidence of anti-knee pain. So there are 60 patients comparing 30 cases of BPTV versus 30 cases of STG at 2 years follow-up. The key findings are there are overall lesser incidence of anti-knee pain than as described in literature. And there is also no statistical difference between both the groups. So an oblique incision can be used for harvesting a BPTB graft. So preparation of the graft. Just with the STG graft, fat pad and post aspect is removed. And bone plug should be trimmed with the ideal sizing of tibia is 10 mm and the femur is 9 mm. Excess bone whichever is removed is preserved for grafting at the harvest site. The ideal measurement should be on the femoral tunnel should be 15 to 20 mm of bone plug. The excess bone graft is preserved. And the tendon bone length is and the rest of the tendon to bone length ranges from 40 to 90 mm is acceptable. So, and the two drill holes are placed in the bone plugs 5 mm apart. In the femoral side, ethibones are both sides or non-absorbed switches can be used, or even SSYs can be used to hold the graft. And it's advised to make markings on the graft on the superior aspect as to avoid graft twisting as we pass through. And then antibiotic preparation of the graft. So the use of vancomycin was first described by Virtual et al. In 2012, and after it seems to be practiced world over. So this is a study published in just April 2023 by Mingwei Hu et al. In BMC journal. So vancomycin is the most preferred antibiotic because it is a hypoallergic, more thermally stable, and also has a good topical safety and has a large volume of distribution, hence reducing the risk of local toxicity. So this is a meta-analysis with 13 studies where they involved 31,000 150 participants. And the ultimate conclusion that vancomycin showcase significantly decreases the risk of infection with a very high significant P factor. So the recommendation is soaking the graft for 20 minutes. Is 20 minutes, which will remove all the infected bacteria. And just for soaking for 20 minutes does not compromise any mechanical integrity and hence can be safely used. Theoretically, vancomycin can be counter-toxic, but studies have shown that the diluted dose on which used after preparation is just higher than the minimum inhibitory concentration for the bacteria and just lower than toxic concentration for osteoblasts and chondrocytes. Hence, there is no proven study to demonstrate vancomycin toxicity with its use, so hence can be safely used. And they also compare the relapse rates with the use of vancomycin without vancomycin. They found that re-rupture rates are similar, hence vancomycin has no compromise in mechanical integrity. So take-home message, when harvesting a hamstring graft, appropriately identify the semity and gracilis prior to the harvest and always harvest the semity first. Ideal graft diameter as recommended by literature with the Western population is 8 mm. And the minimum graft length is minimum graft length which should be in the tunnel is 15 mm in each tunnel. And the periosteal flap should always be included while harvest since it has good healing potential and should be placed in the femoral end. The forced-turn graft technique is most commonly used since it allows for adequate length and diameter, allowing for good hybrid fixation. And any graft prepared should be coated with the vancomycin, which is currently the drug of choice. Thank you, sir.
I mean, you covered majority in detail.
Sir.
Hold on. Sorry. But other graphs you're not covered.
No, sir, I thought.
Okay, fine. Hamstring, your discussion and your theory, everything was complete. And regarding hamstring, you told whatever is required. Did you tell about posterior harvesting, posterior approach?
No, sir, I didn't look it up.
Okay, that's one thing which, in case if you lose your hamstring while harvesting, if you miss it, if it goes inside, you must know how to approach it through posteromedial incision. Some surgeons do take it through.
Okay.
You left out. That's one thing which you left out. Apart from that, when you're preparing it, there are various techniques of preparing it. So you need to know how to prepare various options available, where to put the threads. It should not be in the same line. It should be away from each other so that it doesn't rip off. Nothing much to add to your points which you already told. PTB, there are a few more points. Which is if you do not need always to take a quadrangular graft which you see here. It can always be a triangular in cross section.
Yes, sir.
We did cover majority of the other points. So rest of the graph preparation we are covering in a different talk, or okay, we'll discuss that later. Much to add from my side, sir.
That article by Geethan, on side-to-side stitch. I'm not sure if you mentioned it. Did you mention? Did you come across the article?
No, sir, I didn't come across that article, sir. Only this I came across regarding the incision for BTB.
Okay.
Any doubts from fellows? So if not, we shall go on with the next talk.
Thank you, sir.
Good morning, sir. Am I audible, sir?
Yes, Govind, proceed.
Thank you, sir. Sir, good morning. I'll be presenting on shoulder positioning and draping. Starting with the history, in 1980, Dr. Lanny Johnson introduced the lateral decubitus position for shoulder arthroscopy initially, where the patient is placed in the lateral decubitus position with the affected shoulder, which has to be operated, is exposed and is supported by a vacuum bean bag and a kidney rest. And it was later that was a true lateral position, and it was later modified by Gross and Fitzgibbons to slightly modified lateral, where the patient is turned 30 to 40 degree posteriorly so that the glenoid becomes parallel to the ground. And this is the lateral decubitus position that we use nowadays, where the patient is supported by a beanbag from the posterior side, which is vacuum sealed, and a kidney rest if necessary. And the axillary roll, which can be a fluid bag or a soft solid bag, which is put on the axilla to support the brachial plexus. And the patient's arm is lifted 10 to 15 degree forward flexion for reducing the strain in the brachial plexus. And the patient, as I said, this will be rolled posteriorly to make the glenoid parallel to the floor. When we are putting the patient in the lateral, the things that we have to be careful about is that the upper border of the bean bag should be at level with the patient's upper thorax, but should not protrude into the axilla also. And the patient should be turned onto the non-operative side. The head should be stabilized by the anesthesia team during positioning. And we should ensure a neutral position of the head during the procedure to prevent cervical strain. And folded sheets or under the padded surface may be used to level the head. And placing an axillary roll, just as I said, inferior to the axilla, just 2 to 3 finger breadths inferior, should be adjacent to the chest wall. And the contralateral arm should be placed on a padded arm board at 90 degrees of abduction. And pillow should be placed between the knee as well as under the lower knee to prevent any pressure injuries. This image is also showing the same position. And we should always check for any undue pressure zones in the genitals or areola or bony prominences from the beanbag or even the rigid post system that is connected. And once the patient is secured, and we have to secure the patient at the table using a safety strap, heavy tape must be used to maintain the patient's position. And then later on, the patient's arm will be put onto a traction device. And once all pressure points are padded with pillow, as I've told you, then by tilting the patient, we get the glenoid parallel to the ground so that the orientation is made out. And the traction, the vertical longitudinal traction is applied in most of the cases so that we distract the joint and the glenohumeral joint is well visualized without subluxing it inferiorly. Around 10 to 13 pounds of traction is applied usually with 30 to 60 degrees of abduction. Even up to 90 degrees of abduction can be given with 20 to 30 degrees of forward flexion. This is again a clinical photo demonstrating the lateral decubitus setup with the patient in a bean bag posteriorly, which is vacuum sealed, and the patient's arm has been connected to a traction unit. This is again a different method of applying the traction, where we can apply a sling onto the mid arm so that the forces of traction apply in two directions, one from the mid arm superiorly and one from the distal hand longitudinally. So the problem with this is, if we apply a narrow sling at the arm level as shown in this picture, the chances of vascular compromise to the distal arm is more. So a longitudinal traction alone in the 90 degree is more preferred, unless we are using a broad sling to support the mid-arm. This is an example of a positioning done in our institute. We can see the supports given and the straps given and the head being supported. And this is the usual orientation of the operation table when we are operating in lateral position, where the surgeon stands onto the operating shoulder side, and surgeon and the assistants with the surgical technology technician and the back table. And the arthroscopy tower and the fluid management and section comes from the opposite side along with the traction device. I'll just show a small video of patient being positioned in draped in the lateral position. Patient being positioned and draped in the lateral position. Next, the next, the advantages and disadvantages of the lateral decubitus position. The main advantage being the traction which is given along the along the long axis of the arm increases the space in the glenohumeral joint and the subacromial space, and it accentuates the labral tears which can be visualized easily, and the operating room table and the patient's head, which does not come in the way of posterior and superior shoulder when you're approaching the posterior and superior shoulder. And the cautery bubbles move laterally out of the view when in the lateral position, and there is no risk of increased hypertension or bradycardia as in a B chair position, as well as the cerebral perfusion is maintained. And the disadvantages being it is mainly non-anatomic, so the orientation that has to be made out, the glenoid which is parallel to the floor, is difficult for beginners, and we should reach around for the anterior portal to the anterior side, so that while making the anterior inferior portal, chances of injury to the musculocutaneous nerve is also more. And we may need to reposition and redirect the patient in case we want to convert it to an open procedure. And it is not ideal for patients who cannot tolerate regional anesthesia. And traction can cause neurovascular and soft tissue injuries to the brachial plexus, the axillary nerve, as well as the ulnar and musculocutaneous nerve. The chances of injury becomes more while if the weight attached to the traction becomes more. And there is increased risk of injury to the nerves while putting the anterior inferior portal. So which position is better? This was a study by Rojas et al., which showed this was systematic review, which showed the different injuries that had happened, complications that had happened with lateral decubitus position over the years once it was introduced. In 1984, the study by Andrews et al. Showed 3 cases of musculocutaneous nerve injuries, and in 1986, one more study showed again injury to the musculocutaneous nerve. Later on, studies showed injury to the axillary nerve as well as the ulnar nerve. So that was due to improper padding as well as increased pressure applied at the increased weight applied for the traction. And even the other complications, it was shown again in the systematic review, neuropraxias of dorsal digital nerve of the thumb. Musculocutaneous nerve, maxillary nerve, palsies and DTs which developed, and pulmonary embolisms also which developed. And one more complication was brachial plexus neuropraxia, which happened in a patient with cervical rape. So, which if a patient has cervical, the chances of complication developing will be increased in case of a lateral position. So the pitfalls and the pearls which can be followed in neurological injuries in lateral position, the safety of traction has been advised as 45 degrees of forward flexion and 90 degrees of abduction, or 45 degrees of forward flexion and 0 degrees of abduction. So if you move away from these values, chances of tension to the brachial plexus increases. And another method of traction, as I said, would be a lateral traction to the mid-humerus, which will increase the vertical component of the traction and distract the joint more. But then the detrimental effect in perfusion of the arm because of the constriction of the sling should be considered. And a wider sling should also always be used, and the weight applied should also be reduced. And pressure-related injuries, obviously, we have to check for padding the patient's position properly, and all the accelerators have been kept clearly or not. And next, due to all these complications which developed in the lateral decubitus position, and once it was introduced, Dr. Michael J. Skyhar introduced the B chair position in 1988. This was the first B chair position in his article that was mentioned, that was shown, the figure. And coming to B chair position, the left side, we can see the first B chair position that was described in a article, and the current one which we are following on the right side. The patient is being, once the patient has to be put in B chair position, we have to check the break of the table, the point where the table is flexed, be at the level of the patient's greater trochanter prior to raising the back of the table up, and so that the sciatic nerve is relaxed properly. you can see in this picture, the patient is bringing up almost 70 degree. So at that time, we have to make sure the break of the table is at the level of the greater trochanter of the patient. We have to closely monitor the blood pressure and cerebral saturation during the position as well as the procedure. And the traditional table is the traditional place without the option of removing a part of the table so that the shoulder is exposed. The patient should be shifted towards the operative side so that the middle border of the scapula is just at the side of the edge of the table. And we have to make sure that an adequate access to the operative and satisfactory mobility of the operative arm is achieved, and then place a large pad or several pillows under the patient's leg. And we'll flexing the knees also. So again, the same purpose to relax the popliteal fossa and the nerve while the patient is made to sit up. And then we have to secure the non-operative arm of the patient to the abdomen or to the padded arm port. Then secure the patient's head and neck. That is very crucial. It has to be very stable. And regardless of the method used to secure the head, we have to ensure a neutral position. And if an arm positioning device is used, the care must be taken so that applying the adequate traction only is applied to the arm. And this is again an example of a beater position being done in our institute. We can see that the shoulder as well as the upper part of the back is also exposed fully, with the head being positioned stably, with the padding over the forehead. I'll just go through one video. So again, for the B chair position and draping. And draping. And draping. Draping. Again, coming to the advantages and disadvantages of the B chair position. The main advantage being it is upright in anatomic position, so the orientation becomes easier for beginners. And the ease of examination under anesthesia and the ability to stabilize the scapula is improved. And the arm is not in the way of anterior portal because it is exposed. And no need to reposition or redrive the patient if we want to convert to an open procedure. And can use regional anesthesia with sedation also. Mobility of the surgical arm and ability to set up the arm holder to the operating table becomes easier. And the disadvantages include potential mechanical blocks, the head, example, the head to the use of arthroscope in the posterior portals, and the increased risk of hypertension of bradycardia, cerebrovascular accidents, the ischemia that can happen due to the upright position. And the cautery bubbles can obscure the view in the subacromial space. Fluid flow can happen if there is a leak, which is a back leak from the scope onto the camera, and increased risk of air embolus also. And these are some of the complications which was associated with the BCI position in the systematic review, which was assessing the complication rates of both positions. And it showed the incidence of ischemic brain injury, spinal cord injury, neuropraxia of the lesser occipital nerve, hypoglossal nerve palsy due to improper padding and positioning, and increased cases of DVT also, which is comparable to the lateral decubitus position. And main complication that was associated with this was the cerebral ischemia or the cerebral desaturation events, CDs. So this was a case report which was associated with the Beecher position, which showed the cranial palsy of 9, 10, and 12. The hypoglossal nerve and glossopharyngeal nerve also on a patient which was positioned in Beecher position. This was attributed to the improper positioning of the head, improper securing of the head, and the head went into lateral flexion as well as forward flexion, which compressed the cranial nerves, which resulted in a transient neuropraxia, which lasted for almost 6 months. So this tells us the importance of making sure that the head is fully secured. And again, the pitfalls in Beecher position, mainly to avoid the cerebrovascular events, the patient should be stratified. The risk stratification should be done in the pre-op period. High-risk patients include the extremely obese patients with BMI more than 34. Such patients are at extremely high risk for developing cerebral desaturation events. And the possible risk factors include diabetes, obstructive sleep apnea, hypertension, older patients with other comorbidities, and history of stroke. Such patients, we should always be in a high, we should be alerted even pre-operatively, and if possible, lateral position can be chosen. And if we want to go ahead with the B-chair position, we have to plan for a regional anesthesia in case in versus general anesthesia, which should be avoided. And if a patient has to be taken up in general anesthesia in B-chair position, then we have to make sure that non-invasive monitoring, including near infrared spectroscopy, is available so that proper monitoring can be done in the intraoperative period. And if vasopressor agent has to be used in B-chair position, it is recommended to use norepinephrine rather than epinephrine, so that it lessens the chances of cerebrovascular events. And again, same as in lateral position, the peripheral neurological injury should be kept in mind, and the positioning and the padding of the patient at all bony prominences and securing of the patient should be kept in mind. And this was a study done by Ko et al., which showed the higher incidence of cerebral desaturation events, CDs, in the patients which underwent general anesthesia versus the ones which underwent regional anesthesia. And it is always preferable to do an interscreen block or regional anesthesia in case of a Beecher position. And always, especially in cases of a high-risk patient, it is recommended to undergo near infrared spectroscopy monitoring during the intraoperative period, which will tell us the incidence of CDs. CDs necessarily need not always be converted to neurodeficits in the postoperative period. If the and it was CD was defined as any reduction in 20% decrease in baseline regional cerebral oxygen saturation. It need not be converted to a neurodeficit in the post-op period. May even manifest as confusion and increased vomiting also. And the study showed that you cannot predict whether the duration or the intensity of the CDs will be correlating with the post-operative neurological status. So we can only monitor this amount of CDs using the NIRS technology, and if it is more, we should always be cautious and can even plan on reducing the inclination of the Beecher position. And the safety of controlled anesthesia, a hypotensive anesthesia in shoulder arthroscopy in Beecher position. The current recommendation which is given in the study is that the systolic blood pressure should be at a minimum of 90 degree, and the maximum reduction of both the systolic and mean arterial pressure should be within 20% of the baseline measurements to prevent cerebral hyperperfusion. But in the same study, it was shown that when we are keeping the levels at minimum of 90 and with the SPP and MAP within 20% of the baseline measurements, there were no patients which were affected with any CDs. So it was again proposed in the same study that the cutoff values can be reduced to a newer, safer level also. But the current recommendation is this. And one of the reasons for this is the basal-gyrus reflex, which initiates from empty hypocontractile ventricle, which causes the stimulation of the intramyocardial mechanoreceptor C fibers, which then produces a abrupt withdrawal of the sympathetic outflow. Normally, when you are sitting up, we have an increased sympathetic outflow so that our peripheral resistance is increased and our BP is maintained. So when the patient undergoes general anesthesia, that reflex is lost and the sympathetic outflow is lost. So we tend to be at increased risk for cerebral hypoperfusion. And this is an orientation which shows the orientation that we see intraoperatively comparing the lateral decubitus position versus the Beecher position. So in the first image, we can see the it is a lateral decubitus position, and we can see the part labeled as G, which is a glenoid which is parallel to the ground, and the humeral head, which is H, and B is the biceps tendon, and the superior labrum is marked as L. So the orientation is tilted so that the glenoid is facing parallel to the ground, whereas on the right side, it is more anatomical, and the glenoid is seen marked as G, and the humeral head is seen opposite to it, with the superior labrum seen superiorly to the glenoid and the biceps on the posterior side. So it becomes easier for beginners in the for, getting the orientation right in case of Beecher position. And next, we will just see what are the positioning systems available for us, which are usually available in the market. Which this is a 3-point shoulder distraction system, which is provided by Arthrex. We can see that they use 3 points of distraction. The one at the arm level, which gives the vertical traction, has a wider sling, which is well padded, so that the chances of neurovascular problems is reduced. And then they have a distal longitudinal traction also for distraction. Then this is a Trimana Fortis again by Arthrex, which supports which is again the this again pneumatic fixation device for the arm, which allows us for intraoperative mobilization of the arm of the shoulder during the intraoperative period. We also have, this is the Spider 2 limb positioning system, which is given by Smith and Nephew, which is also again a newer edition, which allows the shoulder to be mobilized in 360 degrees, which allows us for intraoperative visualization. This is the Q-fix system for the lateral positioning. Again, we have a attachment system which helps us, along with the traction, it helps us for 360 degree mobilization of the arm also. So in the lateral positioning, it becomes easier. The one we use here is the one by ConMed, which is similar to Spider 2 system, which helps us in positioning and visualizing the shoulder during the intraoperative period. And again, this is a this is a recent study from Thailand, which showed newer positions, modified semilateral decubitus position. They have advised for shoulder arthroscopy, which combines the advantages of both the position. We can see on the left side, it is a normal position. The patient is positioned for a arthroscopic surgery, where the patient is more in between the lateral as well as the Beecher position, because the anterior aspect of the arm is more rotated externally without an axillary roll. Axillary roll is not kept for the patient, so that he is more kept externally rotated. The upper torso is externally rotated, so that in case of need to open the upper end of the table can be flexed, and it will resemble a beacher position, and the open surgery becomes easier without a need for a redraping. So this is again the same position shown in patient after draping. And once we remove the traction and once we externally rotate the arm, it becomes the anterior aspect becomes easier for a open procedure. Again, the advantages which were given for this position when compared to the lateral decubitus as well as the beacher position, the extra advantage is the easiness of converting to an open procedure, along with all the other advantages of the lateral decubitus position. And the disadvantage being it's usually the disadvantage which are absent in the modified semilateral decubitus position is that it doesn't usually require general anesthesia, can even tolerate regional anesthesia in this position. And the difficulty to control arm rotation in the lateral decubitus position is also avoided up to an extent in modified semilateral decubitus position, whereas once we remove the traction, it becomes easier to rotate the arm. Another position which was again described in Thailand was a supine position for shoulder arthroscopy. The patient is kept in the routine supine position, and the advantages that they were saying is all the advantages of the lateral position along with the two advantages of the beacher position, which include the arm not hanging in the way of the anterior portal and the easiness to convert to an open procedure without repositioning and draping. So the disadvantages for this is again the non-anatomic orientation in the supine position is all since the patient is lying down supine and not sitting up more upright. The non-anatomic orientation will be there. The increased risk of neuropraxia to brachial plexus due to the traction will also be there as comparable to the lateral decubitus position. These are newer positions which have been described, but more studies will be required to assess the complication rates in these positions. And this is a study which was published to assess the time required between the positioning methods of arthroscopy between lateral decubitus as well as beacher position, and it was noted that the lateral decubitus position took up less time to position the patient, whereas beacher took more time since the padding and securing the head took more time for the anesthesia as well as the supporting team. But it was noted again that it did not affect the number of cases that was operated in that day. So it was not even though the time difference was significant between the positionings, it did not make an impact on the number of cases operated that day. So the final impact for the number of cases operated did not make any change difference. And the take-home message include we have to be familiarized with both the positions preferably, and the selection of the position should be based on a case-to-case basis, because if the beacher position may be preferable for rotator cuff repairs or any anterior visualization, whereas the lateral decubitus position becomes better for an instability fixation procedure and visualization of the posterior and posterior inferior part of the joint. So it is always better to be familiarized with both the position, and always strict safety measures should be taken while positioning the patient, as well as aseptic precautions should be taken for draping the patient. Thank you, sir.
Thanks, Govinda. That was a detailed description of the positioning and its advantages and disadvantages. In general, the lateral decubitus position is best suited for any intra-articular workup, and the beacher is preferred for other issues. You have mentioned everything about the disadvantages and advantages, but did you show the lateral decubitus position which we use in our hospital, the picture?
Yes, sir.
Okay, so that is totally different from what has been described in the literature, because ours is a indigenous one, and we have to be very careful in using the amount of traction, and especially when you come across patients with cuff injuries along with brachial plexus neuritis or brachial plexus traction injury. The amount of traction that is needed should be very minimal, and it should be very protective. Commonest mistakes which can happen in our hospital while positioning the patient in lateral decubitus as well as beacher position is undue stretch in the neck during the positioning. So that's the reason why the operating surgeon should always check the position once everything is done before painting. So I generally do that to make sure that there is no stretch in the operating side. Because the patient may end up with neuropraxia, which may be lasting for 6 to 9 months. Next most important thing is always make sure that when a patient is positioned in B chair position, the pillow is kept under the thigh so that it does not cause undue strain to the lower back. This is commonly seen in elderly patients who undergo rotator cuff repair. They may be having L4, L5 disc issues or listhesis, which will get aggravated after surgery. And we have seen patients complaining of severe low back pain after the cuff repair surgeries. So these positioning and padding should be taken care of, and the fellow should always look into what are the various aspects and modifications that we follow. Now, the Arthrex 3-point traction system is considered to be the best, and it is the best for a lateral decubitus position, because it does not cause any traction, undue traction to the neurovascular structures in the neck, but at the same time, it is very effective in providing a fantastic distraction of the glenohumeral joint, which means it gives just vertical traction and not much of a longitudinal traction. So that is good. But I think we are comfortable with our indigenous ones, and the ConMed's limb positioning system is very good for maintaining adequate joint position during the B chair position. So if you want to practice shoulder surgery, you should be well versed in both the positions. It's not like you have to prefer only one. You should be oriented in both the positions, because you have sometimes there will be conditions where you have to approach the labrum as well as the cuff in one sitting. And generally, the exposure or the approach to the posterior labrum is very easy and effective in a lateral decubitus position compared to a B chair position. So that is one pure advantage which I consider if we have to address a posterior labrum. If it is a posterior labrum alone, then lateral decubitus position is needed. If it is a posterior labral issue along with a cuff, then still we can prefer a lateral decubitus position where you can do the labral repair as well as address the cuff repair also.
Thank you, sir.
Carry on. Sorry, and the beach chair position, which you guys see very often, you got to be very careful with. We have very good anesthetists. They know what to do, how to do, and a lot of things they do without your knowledge. And it can lead to a lot of complications. We ourselves have seen earlier a patient used to be intubated and then beach chair. Now that we don't intubate, only block, it's safer. But when you guys go back and see other places, you have to be very careful with beach chair. The anesthetist has to constantly monitor. Thank you.
Thanks.
Sir, good morning, sir. Maz here, sir. Sir, I just wanted to ask, like, what exactly is your take on? Yeah, I know you commented on that. When there is cuff and posterior labrum, and another scenario where there is a cuff and anterior labrum. Is lateral decubitus position enough, or anything else has to be like kept in mind while addressing these kind of different cases? Thank you, sir.
See, addressing labral pathology in a lateral decubitus position is much more easier, because the operating surgeon is comfortable in a comfortable position. So it's your comfort that matters a lot, rather than the patient's comfort in this case. So whereas a cuff can be addressed in a lateral decubitus position, it is very easy. So only thing is you need the appropriate orientation. If at all you're not oriented, it just hardly takes another, say, 5 to 10 minutes for you to get oriented in the subacromial space, but it's not a big issue. But when you're trying to repair a labrum, it has to be properly anatomical. The repair has to be anatomical. For example, if you are addressing a Bankart lesion, it's not just the labral repair that is needed. You need a proper inferior capsular shift, which is very essential part of the repair. And that is usually possible. I would say it is definitely possible only with the lateral decubitus position. We have seen surgeons doing it in the beach chair, but for doing it in the beach chair, you need special instruments like the mini scorpion all those stuff which are needed to take appropriate bites. But here, since we use the suture passing device, the inferior capsular shift is possible in a lateral decubitus position. If given a scenario where I have to address the labrum and the cuff, I would always prefer a lateral decubitus position and then follow it up with the cuff repair.
Thank you, sir. Thank you, sir.
We can go to the next presentation, please.
Is my screen visible, sir?
Continue, Ravi.
Sir, good morning. Today I'm going to talk about sacral joint dysfunction. Sacral joint dysfunction is a degenerative condition of SI joint resulting in low back pain. Usually, SI joint pain is overlooked in spite of 15 to 30% of the patient in outpatient setting because of clinical presentation of intervertebral disc, facet joint, nerve root, and sacral joint disease are often indistinguishable. Sacroiliitic joint is a complex part of kinematic chain connecting the spine and the lower extremities. Come to the anatomy. SI joint is a true diarthrodial joint found between sacrum and iliac bone, and articular surface has many ridges and depression, therefore form an interlocking surface which minimizes the movement and enhances the stability. And there are cellular structures give stability for the SI joint, such as anterior ligament, posterior sacroiliac ligament, and accessory ligaments like sacrotuberous ligament and sacrospinous ligament. And when it comes to nerve innervation, pain pattern in sacroiliac dysfunction varies from person to person because of the varied nerve innervation. According to Cunningham textbook of anatomy states that sacroiliac joint is supplied by it twigs directly from the sacral plexus of the dorsal rami of the first two sacral nerves and branches from the superior
Chetan, are you checking what's happening?
Checking, sir.
There is no audio at all. I cannot hear anything.
Chetan, what's happening? Can you check what's Ravi Teja doing?
Sir, it got disconnected from the ground floor. I'm connecting it, sir.
Sorry, sir. Please, 2 degrees. Passage on test. So, design framework stability 3 fashion flexion and by way one inseparable.
Again, he's disconnected. Is he in the learning center or ground floor, Chetan?
Sir, ground floor OPD.
Chetan, tell them to connect to the 5G which is available in the Wi-Fi, not the ordinary one, the 5G.
The SI joint is 20 times more vulnerable to axial compression failure and twice as susceptible to axial torsion overloading than the lumbar motion segment. Miller and et al. Discovered a threefold increase in sacral rotation with both the iliac fixed versus 2 to 8-fold increase in sacral rotation upon loading with one ilium fixed. Comes to kinematics. The term notation denotes the sacral base movement anterior-inferior in relation to the ilium. During outer rotation, the sacral base moves posterior-superior. The motion occurs in lumbosacral extension and flexion, respectively. Clinical consideration. Several mechanisms of injury may be linked to the development of SI joint pain, including direct fall on the buttocks, a rear end motor vehicle accident, a head-on collision in motor vehicle accident, and a step into an unexpected hole or a miscalculated height. Or due to repeated injury in like athletes who are rowing, tennis player and golf players, and people with limb length discrepancy, and people with previous lumbar spine fusion surgeries. Additionally, the past medical history should be noted. History of polyarthritis, lumbar fusion surgery, and pregnancy. All patients with suspected presentation of SI joint pain should have the necessary laboratory and radiological workup for the psoriatic and metabolic or infectious etiology. Etiology. Exact cause is unclear, as idiopathic is the most common cause. Arthritis, infection, and metabolic and tumors, and HLA-B27 and rheumatic should be causes, and associated conditions like lumbar spine fusion and post-traumatic arthritis. And other etiologies are limb length discrepancy, gait abnormality, prolonged vigorous exercise, scoliosis, pregnancy, and spinal fusion, and sacromatic pathology can cause SI joint pain. Clinical picture: pain below the belt line with radiation into the groin and lower extremities, infrequently with radiation below the knee in the L5 and S1 dermatomal pattern. The pain is aching in quality with absence of burning quality or numbness and tingling sensation. Pain is often with movement and can radiate into the ipsilateral groin and the buttock. The pain will get worsen on prolonged sitting, bending forward, and transfer out of the bed or up from the low chair or toilet. Pain in this patient may worsen after performing the weight-bearing activities such as climbing stairs, bending, twisting, or even prolonged walk. Comes to investigation, examination, 14-finger test. When patient asked to spot the most tender or painful part, patient used to usually show posterior superior ax pain or venous vertigo. And special test, provocative tests are Faber's test, Tither's test, and sacral distraction test, and iliac compression test, and Ganselin's. Faber's test. Patient is positioned supine, and the leg is placed on the figure of 4 fashion. Hip is flexed, abducted, external rotated, and ankle is placed on the contralateral thigh, stabilizing the opposite side of the pelvis. When downward force is applied on the flexed knee, patient will feel the pain. And Faber's test has more sensitive, good sensitivity of 91% and specificity of 77%. And distraction test, patient in supine position, when pressure applied outwards, pressure at the SIS, patient will reproduce the pain. It has little lower sensitivity and specificity. And Tither's test has sensitivity of 90%, specificity of 66%. When patient lying supine, tested hip should be flexed 90 degree and anterior posterior shearing force applied to an SI joint through the axis of the femur. Compression test, patient made lie in lateral decubitus position with the affected side upwards and applied a downward force on the iliac crest. It has a sensitivity of 62% and specificity of 69%. Gans length, it has the lowest specificity. Patient is positioned supine with affected limb rested hanging down the bed, and the sound side should be flexed. International Association of the Study of Pain criteria. Diagnosis must made with 3 or more positive probability tests with the highest sensitivity of favors of 91.4% and lowest with the Ganslin's test. Proposed criteria for diagnosis of sacroiliac joint dysfunction can be included when the pain in the area of sacroiliac joint, and the pain should be reproduced with the provocative manner, and pain relief with the local anesthesia injection into the SI joint. The joint is difficult to profile well on the radiographic view, and therefore radiographic finding of sacroiliitis are often equivocal. MRI is the most sensitive imaging technique to detect a sacroiliitis related to HLA-B27 seronegative spondylorthopathies like psoriatic arthropathies, ankylosing spondylitis, and inflammatory bowel disease with associated arthritis and reactive arthritis. Due to its high sensitivity and ability to visualize bone marrow and SI joint edema. Recent studies have shown that image-guided injection of local anesthetic is the gold standard for diagnosis of SI joint pain. New York criteria for grading sacroiliitis. Grade 0 is normal. Grade 1, suspicion changes, some blurry of joint margin. Grade 2, small localized area with erosion, sclerosis with no alteration in the joint width. In grade 3, moderate to advanced sclerosis with erosion and evidence of widening and narrowing with partial ankylosis. Grade 4 is complete ankylosis. Differential diagnosis: lumbar spinal stenosis, degenerative disc disease, lumbar disc herniation, and hip osteoarthritis and hip labral tear. Management: non-surgical treatment options are conventional medical management. NSAID may be effective as initial regimen to target the myofascial and inflammatory component of the pain. And conservative modalities like physical therapy and less invasive interventions such as nerve block and neuroablations. Periodical injections. A recent review of 15 publications related to the spondyloarthritis showed that a good response was reported in more than 80% of the cases with mean duration of improvement over 8 months. 85% of the subjects reviewed from the other observation study also obtained significant pain relief lasting for around 10 months. Diagnosis of therapeutic injection should be performed using the aid of fluoroscopy. As studied shows that only 22% of non-radiological guided SI injection extends into the joint space. Image showing the USG guided injection and fluoroscopy guided. Neuroablation technique. If conservative and SI joint therapeutic injection have failed to provide relief, neuroablation technique are an accepted next best step to manage the painful SI joint. Subsequently, radiofrequency lesion in the posterior inferior aspect of the joint by leapfrogging an electrode at least less than 1 centimeter interval. Intraarticular phenol, radiofrequency ablation targeting the lateral branch of primary dorsal rami of from L5 to S2 has met the more auspicious results, with most studies reporting sustained relief lasting for at least 6 months in 60% of the subjects. And surgical treatment option. Surgical stabilization and fusion of the sacral joint should be considered when the patient has persistent or moderate to severe pain, functional impairment, and failed to minimum of 6 months of intensive non-operative care. Can be done with 2 approaches, lateral approach and posterior approach. A review and algorithm in a diagnosis and treatment of sacral joint in a US study shows if pain Diagnosis of SI joint injection should be if the pain is reduced in more than 70%. 4-week course of NA should be continued. If pain is not reduced, evaluate the other causes of low back pain.
Have you any role for PRP injections? You told about injections. What exact injection was it? Steroids or anything else?
Local with steroids, sir.
Any role for PRP?
Yeah.
So, Sriram, any role for PRP over here?
தெரியலைங்க not very sure. We'll find out.
We was not sure. Yesterday we had a discussion. Previous sir was asking. I was also not sure, but we can explore that as an option. I'm not sure really, literature-wise. Sir,
I know I. Oh my, what's this?
you're audible, sir.
Yeah, but some getting echo. Okay. No, earlier I've seen some surgeons and giving frequently with a lot of relief. I think Sriram is not very fond of it. Yeah.
Not like that, sir. I don't have any experience. I'll find out, sir.
Yeah, because we have some people asking for PRPs and
Yeah, nowadays they do.
instead of steroid, where I mean, definite inflammation will come down. If it's for tendonitis, tendinosis, for us, steroid is going to further degenerate the tendon and result in a tendon tear, especially in foot and ankle. Dr. Vidyasagar will help us out in sharing that knowledge. Over there, PRP is better than a steroid because of, especially in an athlete, younger individual, where it reduces the inflammation and doesn't harm the tendon. I'm not sure in the joint inflammation. Arthritis, we are giving for patients who are asking for it, who wants to delay certain other procedures. But you can always have it as an option, but not to promise anything drastic or great relief. What's your experience on the ultrasound guided injections, Sriram? You've been doing it now.
Yeah, ultrasound guided injections do work the same way like what we do in the theater. The biggest advantage is we are able to do it in OP basis, and it's
Less
easy, much easier.
So it's easier in ultrasound guided.
இல்ல மற்றபடி results are same as like what we were getting when we used to put it in the OT.
So definitely it'll be time saving, and when you do an OP basis and send the patient on, you
Same.
don't admit at all.
We keep them for half an hour to 1 hour and just have a then send them back home.
So, I mean, what are your indications for these ultrasound guided injections among the sacroiliitis patient? When do you advise them injections, and when do you continue to treat them conservative rehab?
Indication is the same. When we start them, basically, I used to put them on naproxen. Once we have ruled out other causes, it can be done for this HLA-B27 positive or spondyloarthropathies. Everything is an indication. We can use it in any patient. Basically, it's like we start the patient on naproxen, which is supposedly the most effective NSAID as far as sacroiliac arthritis is seen. And minimum we go for 6 weeks time. If at the end of 6 weeks also they don't respond, then along with the physio exercises and all, we go for the injection.
How is it, Ravi? How is the literature on ultrasound guided injections? I mean, is it very commonly practiced method, or it's not so common? No, is it worth publishing this? Is my question.
No, it is very commonly done thing.
Okay.
Very common.
Any kind of comparative study, any kind of study which you can do?
Ultrasound, it is a very well established procedure.
Okay.
பண்ணலாங்க, but ஆனா then yeah, it's
Maybe PRP versus steroids.
With PRP, maybe yes. Yes.
Okay. Something like that can be designed.
Okay. Okay.
Thank you. Sir, any points? No, you're not audible. You're traveling. Okay. If, any other points or doubts from fellow?
Maybe I can request Sriram for various treatment of SI joint arthropathy. See, so many of them. They always say SI joint arthropathy and the treatment alone. They can ask one of the spine fellows to review and tell us what it is.
Sir, you mean whatever we have done so far or reviewing, does that? Like?
Also, yes, of course.
Okay, sir.
Well, plus, what is new?
Okay.
What the current concept? What does it say?
Okay,
Sriram.
Yeah, because everywhere PRP. Yesterday, we gave PRP injection for a patient because they insisted on it. Yeah.
Sriram, I wanted to know at what point do you decide to do a sacroiliac joint fusion?
If they don't respond for more than 6 weeks, sir.
No, fusion.
Oh, fusion. Fusions so far we have not done, sir.
Because recently I've read a couple of articles, very successful sacroiliac joint fusion for chronic SI arthritis following injections and things like that, published from Hospital for Special Surgery, the Spine Service.
Yeah, but sacroiliac fusion is there for a very long time, sir.
Yes, I know.
Yeah. I don't know, sir, whether it's really that indicate in our patients. Here, we have not found that bad a patient who has not responded at all. But maybe, sir, it definitely has an indication, sir. Even I have assisted a few cases in UK, but I don't have a personal experience of doing it.
Okay. So most often, the patients who come to us, I tell my fellows, where is the patient from? Most of the time, they do not know. And they're from Namakkal, Trichy, Thiruvarur, and all these places. They take a lot of pain to come all the way to us. They come to us for the final, decision. And after that, they're not going to go anywhere. And very often I've seen, I've tried all the night myself. You take tablet and come back after 3 weeks. They never come back. So we have to consider the fact that the patient has taken all the trouble to come to us after treatment locally. So we had to take that into consideration and give a definitive kind of treatment so that the patient gets well after coming to our program.
If no more points to discuss, shall we close the meeting, sir?
Thanks, Gopal, for joining. Glad to hear that you are doing well.
Yes.
Thank you. Thank you.
Yes, I'm feeling better. Thank you. Thank you.
Right.
Good night.
Right.